Good evening, sir.
Good evening, ma'am.
How are you, sir? Don't call me ma'am.
Okay.
Hi, Kirti. All set?
Hi, ma'am. Yes,
All the best.
thank you, ma'am.
So everybody shared their presentation.
Yeah, we have shared on the group, plus we will share our screen on our own. If there is any problem, there is a backup.
Yesterday somebody could not share, na?
Radhika could not share, but she will be sharing from Deepa's laptop.
Acha.
Have you all mailed it to Ganesh or just shared on the group?
Shared on the group.
Okay. Ganesh, you have noted na, that the present PPTs are on the group.
Ganesh was there sometime back. If somebody wants to share and just see, then it's fine. Anyone wants to try it out? Yesterday who could not share?
Madam, from the same laptop, we are going to share the two sessions, diabetes and pheochromocytoma. So that yesterday we checked it, and again we can try it. And then the other presentation is with the KTP. So other two clubs which are going to share the screen.
Okay.
How many members are there of the society in Thane at least?
So we are 117 members.
In
Correct.
Thane?
Yeah, no, Thane has many more actually. We must be having around 125 to 150 anesthetists. And the Indian, so some are not ISA members as yet, but otherwise we have a strength of around 125.
Okay.
Yeah. Good evening, Dr. Katkade, sir.
Hello everyone, good evening.
Hi, Shamini.
Hi.
Hi, Nilima. Hi, Shamini.
Hi.
Hello, everybody. Katkade sir is there. Hello, good evening, sir.
Hello. हाँ, Dr. Tagadpalle. Good evening. बोला ना.
Hello, good evening. कैसे? How are you?
Good evening, sir.
Yeah.
Hi, Manisha, Parna. Okay, everybody. Okay, so all the best.
Thank you. Ketki and her team has worked very hard. Hello. Tagadpalle sir had called. He sent his best wishes.
Yeah, he just called me also. Yeah. If you all have registered, then there is no need to type again in the chat box because your details are already with us. And it is difficult to access these when we are conducting a meeting. So please register through the Google form that we have circulated. There is no need to type on the chat box. Thank you. Parna, let me know when we can start. It is 6:30 now.
Yeah.
Hello, Minal.
Hi.
After a
yes.
long
Oh,
time.
hello everyone. Namaskar, Patwardhan
ma'am.
sir. Namaskar.
Oh, thank you.
Dr. Minal is our immediate past president, sir.
Okay.
She has set a very high bar for us, actually.
No. निशा जसे हे आली छान करून आली जमलेत ग खूप लोक
हो 50 झाले येतील ते सगळे एक
येस
15-20 मिनिटांनी भरायला लागतं हळूहळू.
Hi,
Yes,
हाय
Meena.
केत
like I said,
हाय
almost
पर्णा
How
registration.
are you?
Hi, ma'am. Hi, ma'am.
फाईन हाय नाईस टू सी एव्हरीवन
Yes.
आय मिस्ड अवर कल्चरल प्रोग्राम
Yes, we missed you a lot. It
हाय
was very
विजय
nice. It was very nice.
तेरे
या
बहुत ही ज्यादा बुरा था. Can we start Parna? 6:31.
Arey, lots of people are calling, yeah. Lots of people are calling. We'll start at 6:35.
Okay.
So,
मनीषा इज व्हेरी पर्टिक्युलर
yeah, 5
No,
minutes.
nothing like that. We want people to join in.
I think now the queries have settled.
Yeah, okay.
Yeah. Otherwise, at one point, too many people were calling. Yeah.
Nice. I think we can start now. Sir, can we start?
Sure.
Yeah.
We should.
Thank you. A warm welcome and good evening to everybody who have joined here today for this webinar, which is conducted by Thane Anesthesia Society along with the Department of Anesthesia, Rajiv Gandhi Medical College, Kalwa, under the aegis of SAMS, Maharashtra State. And we are thankful for everybody for joining in. So endocrinology is a very interesting topic because there are so many of these endocrine glands scattered all over the body. And as long as they are behaving well, everything is fine. But if one gland also decides to deviate from the normal, then there can be a lot of trouble. Especially if such patients we have to anesthetize, then there are much more precautions and a lot of detailing that is required. So it is very heartening and my honor to welcome Dr. Milind Hari Patwardhan, who's an endocrinologist and an expert in all this, in endocrinology. Sir is the alumnus of PGI Chandigarh and currently the assistant professor of medicine in GMC Meerut and an endocrinologist at Wanless Hospital Meerut. He is the president of Maha Endocrine Society and a trustee of the ADAMS. He's also the secretary of Madhumeha Jagruti Manch, and he has authored many publications. We are very honored to have him with us today, and welcome, sir. Today, we also have in the first lecture, the first topic will be delivered by Dr. Ketki Patwardhan Nirki, and she is also a chip of the old block. I think this is a very unique seminar where we have the father and the daughter together on the same platform. So I think this is a record of sorts for not only Thane Anesthesia Society, but for many societies. Ketki is an additional professor of anesthesia at RGMC Kalwa, and she's more famous as a writer of many psychological thrillers, and her short horror film is soon to be launched. So we are very proud of Ketki. Along with her is her great team of Vijay Patil and Deepa Bulchandani, or Anmol Lalwani as she calls herself now. And they will be introduced as we progress through. So now I request Ketki to take over.
Thank you, ma'am. Was my screen visible when I shared it?
Yes.
Okay.
I would request everyone to mute themselves, please. And Ganesh, सगळ्यांना mute करायला होतील ना?
Yes, madam, yes.
Okay, thank you.
Only Dr. Patwardhan and myself should be unmuted right now for this session.
Yes.
Okay. So, good evening, everyone. Is my slideshow visible?
Yes.
Yes, visible.
Yeah. So, good evening, everyone. We are starting our webinar with one of the most common diseases that we as anesthetists come across, that is thyroid disorders and thyroid surgery. I would like to mention here that, as we all know, thyroid surgery itself is a very big topic that encompasses many aspects such as airway management, recurrent laryngeal nerve palsy. However, in today's webinar, I will be restricting myself to the endocrine aspects of this topic. With our guest speaker, an eminent endocrinologist to guide us, let us get clarified about the day-to-day dilemmas that we face as anesthetists while dealing with patients coming with thyroid diseases and for thyroid surgery. So our main focus will be the investigations and the preoperative preparation and some relevant discussion of intraoperative aspects. Coming to thyroid disorders, due to the myriad effects of thyroid hormones throughout the body, the effects of thyroid dysfunction are manifold and may complicate surgical procedures and postoperative recovery. Thus, although routine screening to detect thyroid disease is not indicated in patients where there is no index of suspicion for the same, the recognition, diagnosis, and optimization of pre-existing thyroid conditions in patients undergoing surgery are important perioperative considerations. So thyroid diseases with anesthetic implications are hypothyroidism, hyperthyroidism, and conditions that require thyroidectomy. Now, generally well-controlled hypo or hyperthyroidism do not pose much anesthetic problem. However, uncontrolled myxedema or uncontrolled hyperthyroidism, especially posted for emergency surgery, have lots of anesthetic concerns. In addition, there are other problems such as airway problems in retrosternal goiter or patients with long-standing goiters leading to tracheomalacia, vascular injuries like bleeding or hematoma, complexity of surgical intervention, and other comorbidities. So in the preoperative assessment, the primary goal in patients presenting for thyroid surgery is to ensure a euthyroid state. Besides thyroid hormonal levels, huge emphasis is given to the assessment of any potential airway management. So elicitation of history should include symptoms related to hyper and hypothyroidism, as well as any comorbid medical diseases. So we are all well versed with all the signs and symptoms of hypo and hyperthyroidism. There is a long list of, because it affects almost all organ systems of the body. So here I will like to ask our expert, which are the specific clinical features that we should focus on so that we should not be, so that we should not miss any undiagnosed hypo or hyperthyroidism during our preoperative evaluation.
Good question. See, basically, hyperthyroidism, I give main importance to weight loss. There is very unlikely that a patient has thyrotoxicosis and is gaining weight. So any weight gain should exclude thyrotoxicosis. But weight loss is an important feature, and people can lose up to 10 kgs of weight in 2 to 3 months of time of uncontrolled thyrotoxicosis. So weight loss, tachycardia, resting tachycardia, tremulousness, excitement, agitation, and looking at the eyes, you surely know whether patient has Graves' disease or not. Because mild proptosis or lead lag also is easily can be picked and you can differentiate it. So these 3-4 things are very important. There may be a long list in thyrotoxic storm. You get scoring also, but main thing is weight loss, heat intolerance, tachycardia, and eye signs. If you go to hypothyroid side, mainly puffiness of the face, lid edema, loss of lateral third of the eyebrows, non-pitting edema on the limbs, and obesity. These are important signs. Voice also points to the huskiness and low tone. So these some of the indicators should always make you suspect that patient may be hypothyroid and should get a minimum thing is to get a TSH. Yeah, next.
Okay. So which are the red flags? Of course, one is untreated or severe forms of hyper and hypothyroidism coming for emergency surgery. A large size goiter which may be present for a prolonged duration because it indicates that the patient may be a potential candidate for developing tracheomalacia, which is important especially during extubation. Difficulties encountered during normal breathing and respiration, such as dyspnea, orthopnea, dysphagia, stridor, breathlessness on assuming supine position, may point towards a retrosternal goiter, and a rapid increase in the size of the goiter may be due to either hemorrhage or, in rare cases, due to rapidly enlarging malignancy that can cause airway management difficulty. So the clinical and physical examination involves a multidisciplinary approach. So it involves the active role of endocrinologist, surgeon, cardiologist, radiologist, and anesthesiologist during the preoperative evaluation uh, to give a precise diagnosis of the degree of thyroid derangement and other comorbidities. So these we all know these are the investigations that we routinely perform in any elective surgery, and the highlighted investigations are the investigations they specifically ask for, especially in thyroid surgery. So coming to the thyroid function test, the major thyroid hormones are T4, which is a prohormone, and T3 or 3,5,3 triiodothyronine, which is a product of both thyroid and extrathyroidal enzymatic deiodination of T4. Under normal circumstances, approximately 85% of T3 is produced outside the thyroid gland. Production of thyroid secretions is maintained by the secretion of thyroid stimulating hormone or TSH from the pituitary, which in turn is regulated by the secretion of thyrotropin releasing hormone TRH from the hypothalamus. Secretion of TSH and TRH both are negatively regulated by feedback from levels of T4 and T3. So I would like to ask the expert a few questions regarding this. First, what are the clinically relevant investigations that should not be missed preoperatively in hypo and hyperthyroid patients?
I think you have evaluated this list, which commonly is done preoperatively. But in
Right.
hyperthyroid, we also would like to have ECG, echo to assess cardiac status. In hypo, usually T3, T4, TSH, and a lipidogram, creatinine, and sodium potassium are sufficient additional investigations.
Okay. How essential is being euthyroid before surgery necessary for elective cases, in your opinion?
This is very much necessary. You should always select a patient who is euthyroid and is on drugs, either thyroxine or antithyroid medicines, for at least 3 to 4 weeks before surgery in a elective. In case of emergency surgery, you have no choice but to go ahead. But then as the time evolves, I'll tell you what are the problems with emergency surgery.
Okay.
Symptom,
So,
yes, I have read this question. How do the thyroid function test correlate with symptomatology? No,
so
unfortunately,
basically, can we predict that at certain TSH level, maybe the patient might develop cardiovascular symptoms or something like that? Can we relate the thyroid function test results to the
good
symptomatology?
question, but answer is no. There is no correlation, absolutely. Patients cannot be differentiated. Patients with thyroid storm and patients with non-thyrotoxic, I mean, what do you call decompensated thyrotoxicosis versus compensated thyrotoxic. That is the term which we use. Thyrotoxic storm is extreme condition of decompensation. But you cannot predict that from T3, T4, TSH levels. Only thing people in some of the papers, free T4 has been found to correlate with future development of thyrotoxic crisis. But again, why there is no correlation? Because the basic difference is not actually in the thyroid hormone level, but the binding of thyroid hormone to the thyroid binding globulin and the sensitivity of the thyroid hormone receptors. These mainly decide whether the patient will become thyrotoxic crisis or not. So ordinary biochemical levels cannot tell you in a predictive fashion.
Okay. And if the patient is clinically symptom-free, still is it necessary to have a chemical euthyroid state?
Absolutely, because symptom-free has no meaning. What we divide is only a frank clinical hypothyroidism versus subclinical hypothyroidism. Similarly, clinical thyrotoxicosis and subclinical thyrotoxicosis. Now, these differences are made to correlate with the complications during surgery or in post-operative state. But clinical symptomatology-wise patients may be feeling okay because of treatment, but is not fully chemically euthyroid. Then if it is elective situation, you should again postpone. You should have chemical euthyroid state as far as possible.
Okay. Is it true that T3 is the only biologically active hormone and T4 is just the pro-hormone? And if so, should the diagnosis of thyroid disorders be based entirely on T3 levels?
It's a tricky question in the sense that it is true T4 is a pro-hormone, thyroxine is a pro-hormone, and T3 is actual hormone. But in day-to-day practice, actually, T3 levels do not help us at all. In fact, for last 30, 40 years, I have stopped ordering T3 at all. We decide most of the things from T4 and TSH, and sometimes we get free T4 and TSH. Now, why it is so? Because 80 to 85% of the hormones secreted by the thyroid gland is T4, and only 20% secretion of circulating T3 comes from thyroid. So, remaining 80 to 85% of the circulating T3 is actually peripheral conversion of T4 to T3, mainly in the liver, but at all tissue levels. So, reading a serum T3 level doesn't give you an idea as to what is happening at the cellular level. Now, normally, for example, when we give thyroxine to the patient, this thyroxine, when it reaches to different tissues as a free T4, then the deiodinase present in that tissue decides how much T3 the cells need, and only that much T3 is generated from the T4. You follow this? So circulating T3 has no actual effect on the cellular T3 levels. So the body is quite wise. It will decide how much T4 it needs, T3 it needs and produce it. So therefore, basing your diagnosis only on T3 levels is absolutely wrong. Secondly, this conversion of T4 to T3 into active hormone is dependent upon so many factors, so many non-thyroidal factors, non-thyroidal illnesses, so many drugs, starvation, obesity, and so many things, that T3 is most of the time low due to non-thyroidal causes. So this is called as non-thyroidal illness presenting as low T3 syndrome. Sometimes it can be low T4 syndrome when it affects the binding globulin. So we'll come to that if you have a slide where patterns of thyroid function we can discuss.
Okay, and many times only the TSH value is available and T3, T4 levels are not available. So in such case, should we rely only on the TSH levels or should we ask for T3 and
Ideally
T4?
not, because you should rely mainly on combination of T4 TSH. That will help you to identify where the pathology is primary, that is at thyroid level, secondary at the pituitary or hypothalamic level. So only based, for example, TSH is very low in thyrotoxicosis, but it is also low in pituitary diseases, which is a cause of central hypothyroidism. So if you get only TSH, then interpretation will be wrong if you do not know what is T4. So this is again, we'll come to discuss sometime when you have got patterns of thyroid dysfunction. And when there are conditions like high TBG level, for example, pregnancy, or a patient is taking contraceptive pills, or patient has nephrotic syndrome where T4 is, proteins are excreted. So their free T4 is more important than actual total T4.
Okay.
Okay.
Yeah. So in majority of cases, the results of the thyroid function tests are straightforward. However, there are some instances when the interpretation of thyroid function tests is more challenging. So either the results appear discordant with the clinical picture, for example, like you said, normal TSH in a patient with suspected thyrotoxicosis, or there are different measurements which appear to contradict each other, such as raised TH concentrations but non-suppressed TSH. So what should we do when the preoperative thyroid function tests are discordant or difficult to interpret? Now, the reason I'm asking this question is obviously we are not supposed to diagnose the patient, but many times when a patient is posted for elective surgery and there are discordant thyroid function tests, what are the red flags which should alert us that this patient needs a more detailed investigation by going to a physician or endocrinologist, and which types of discordant tests we can consider say not to be a red flag?
Yes, this is the classical side to show you different patterns of thyroid dysfunction. Now you should be clear that if you have got normal T3, T4, TSH, at least patient is euthyroid and you have excluded hyper or hypothyroid state. So that is not a problem. But then you can find nearly 7 different types of abnormal patterns can be there. For example, one is elevated T3 and T4 and suppressed TSH. This is called as thyrotoxicosis pattern. In the same pattern, there is normal T3, normal T4, but suppressed TSH. This is called as subclinical hyperthyroidism. These two you can identify and decide to treat or alert surgeon that this is the problem. If patient is subclinical, we should have cardiac opinion and so on. Similarly, if a patient has got very low T3, very low T4 and raised TSH, this is clear-cut, simple, straightforward primary hypothyroidism. If the patient has normal T3, normal T4, but raised TSH, it indicates subclinical hypothyroidism. Now, why this is important? Because even though T3, T4 are normal in these situations, raised or suppressed TSH indicate that there is underlying pathology. And this pathology is associated with poor recovery and some complications in intraoperative or postoperative period. So you should be aware of these minor subclinical abnormalities also. Now, this much is very clear. This you can decide, identify, diagnose, and treat. But sometimes, as we said, we get a discordant pattern. Like when T3, T4 is high, then you expect TSH to be suppressed. But if you get a pattern of T3 is high, T4 is high, and TSH is also high, then something is wrong. Either the laboratory is wrong, so you need to repeat the test, or there are conditions which are called as peripheral resistance to thyroid hormone, pituitary resistance to thyroid hormone, or pituitary TSH secreting adenoma. These can present like this. They have high TSH because of adenoma which secretes TSH. At the same time, this TSH produces thyrotoxicosis. So it looks very odd that T3, T4 are high, but the cause is raised TSH, not suppressed TSH. You follow this? Same is true for the non-thyroidal illnesses. As I said, any non-thyroidal illness suppresses first the generation of T4 to T3. So it is as, you can say, as good as ESR. The high ESR only indicates that there is some abnormality. If higher the ESR, you are more worried to find out what is that cause. Similarly, low T3 with normal T4, normal TSH indicates some abnormality which is non-thyroidal. Maybe pulmonary tuberculosis, maybe pneumonia, maybe myocardial infarction, maybe patient is taking anti-epileptic drugs, maybe having ordinary influenza also. So anything in the body, anything happens, body wants to conserve energy and therefore it decreases the T3 production. So this is a sort of protective device from the body, and therefore low T3 syndrome alone does not indicate any thyroidal abnormality. It actually prompts you to find out the cause of this low T3 in the non-thyroidal illness. If you get low T3 and low T4 syndrome, then it prompts that the disease which is causing low T3 is quite serious, and the seriousness or the severity of the illness in such cases correlates with the depression of the T4 which has occurred. Again, in such situation, you cannot interpret it properly. And therefore, I would suggest that apart from frank biochemical hypo and hyper, as well as subclinical hypo and hyper, if there is any other suspicious abnormality, you should request the surgeon to get a proper endocrinology opinion. You can discuss it with endocrinologist and then decide what should be done next. Is it clear?
Yes. The next question is there any difference in interpretation of thyroid function tests in critically ill patients?
Yes, this is another very important area, because as I said you just now, that any illness produces decrease in the T3, and more severe the illness, it also produces decrease in the T4, and decrement in the T4 actually indicates the severity of the illness which is producing all this mischief. And therefore, in such situation, low T4 is used as a prognostic indicator for the mortality from the non-thyroid illness. So in a critically ill patient, you should not order a new thyroid function test. That is rule number 1, unless you suspect that the critical illness is actually thyrotoxic crisis or myxedema coma. You follow this? So where there is high clinical suspicion in the ICU of the main disease being thyroid, either myxedema or thyrotoxic crisis, then only there is point in getting T3, T4, TSH evaluated. Otherwise, in ICU setting, it is very difficult to interpret. There are so many drugs going on in the ICU like dopamine, glucosteroids. They suppress TSH production. Patient has got inflammation, cytokines, inflammatory cytokines. They suppress TSH production. So getting a result of low T3, low T4, low TSH does not indicate central hypothyroidism in such patients. It indicates more severe general, whatever secondary non-thyroidal illness is going on. So my feeling is, ideally, you should not order T3, T4, TSH in an ICU or critical care setting. If by chance you get the report, then see whether patient really has signs or symptoms as suggested by the report. Ideally, such patient should have a repeat T3, T4, TSH at 3rd week. That shows the recovery process. And during recovery, there is overshoot of TSH. So you get TSH levels up to 20 also, which should not prompt you to diagnose hypothyroidism in such patients who are recovering from the serious illness. So you wait for another 3 to 4 weeks and then decide whether patient is really euthyroid or hypothyroid or hyperthyroid. So do you feel this is very important message I would like to again give to all those who take care of the ICU patients, that T3, T4, TSH should ordered in the ICU settings unless you suspect the patient is suffering clinically from thyroid illness. Okay.
Okay, yeah. So again, I have summarized the conditions in which measurement of TSH alone may be misleading, which we have you have already clarified. So any recent treatment for thyrotoxicosis, non-thyroidal illness, TSH assay interference, central hypothyroidism, TSH secreting pituitary adenomas, resistance to thyroid hormone, and disorders of thyroid hormone transport or metabolism. So coming to the preoperative preparation of hyperthyroidism, the main goal during any elective thyroid surgery, as we discussed, is the preoperative optimization of thyroid function and ensuring normal thyroid hormonal levels. So we have to determine whether the hyperthyroidism is under control by looking for signs and symptoms of a hypermetabolic state, review the TFTs, see the medications and the treatment duration. So I would like to ask the expert, which drug do you prefer for hyperthyroidism treatment and why?
Okay, we have mainly 2 types of drugs. One are called as imidazoles, that is methimazole, carbimazole, and second is thiouracil type, that is propyl thiouracil. Now, these 2 drugs act in a similar fashion to suppress the thyroid hormone synthesis and release. But commonly, the most effective drug is methimazole. The second drug is carbimazole, which is actually a prodrug. In the body, carbimazole is converted ultimately to methimazole only. So that carbimazole is slightly less potent, less active. So these 2 are the drug of choices. Methimazole we prefer. We can give it in small dose. It acts rapidly and it is also quickly acting. That means euthyroid state is achieved by about 3rd week or so. Carbimazole take a little bit more longer time. And propyl thiouracil has milder action and therefore requires higher dose, like 5 milligrams of methimazole is equal to 10 milligrams of carbimazole, which is equal to 50 to 100 milligrams of propyl thiouracil.
Okay.
Higher doses of thiouracil or propyl thiouracil can decrease conversion, peripheral conversion of T4 to T3, and therefore may be recommended in thyrotoxic storm, etc. But otherwise, the drug of choice is methimazole. If that is not easily available, carbimazole. Both these drugs cause increase in the vascularity, that is trouble during surgery. But previously, at least we used to use iodine to prepare the patient for surgery, and that would take care of vascularity.
Okay, so now how do you optimize a patient? If your patient, hyperthyroid patient, is posted for surgery, so how do you optimize that patient? Which
Number
drugs
1 is
you
patient should be first made euthyroid. So after about 3 to 4 weeks, most of the patients are euthyroid. Patient should not be over-treated. That is, should not be going into high levels of TSH. So clinically, he may look normal, but TSH is high. Such patients are subclinical hypothyroidism due to treatment, and therefore that should also be looked into and dose can be slightly reduced. Previously, we used to give 3 weeks or at least 2 weeks of Lugol iodine or SSKI. Iodine causes immediate suppression of thyroid hormone release. But iodine should always be given after you have made the patient euthyroid by giving thionamides or antithyroid drugs, because iodine supplements the thyroid's iodine store. And if you have not stopped the synthesis of thyroid hormone by giving neomercazole or methimazole, then the only giving iodine can produce more thyroid hormone secretion. Unfortunately, in last 20 years or so, Lugol iodine is not marketed or not available. So sometimes you used to get it from some pharmacies like Mission Hospital or some other pharmacy. But at present, we avoid Lugol iodine. So mainly we prepare the patient by giving adequate doses of methimazole or carbimazole and good amount of beta blocker, because beta blockade is the most important thing to take care of during surgery, and that can be done along with the treatment of thyroid, antithyroid drugs. Beta blockers also help, some beta blockers, for example, propranolol, to decrease the peripheral conversion of T4 to T3, and therefore also beta blockers are useful.
So that brings us to our next question. Which beta blockers do you prefer? Do you prefer selective or non-selective, and why?
One can prefer selective or non-selective, but we usually prefer non-selective, because non-selective, for example, propranolol, is lipophilic and therefore crosses blood-brain barrier, and therefore is useful to suppress agitation, anxiety, and central sympathetic, you can say, release of the adrenaline, etc. So non-selective beta blockers are wide spectrum of action. In selective beta blockers, we choose metoprolol or atenolol. Usually, we avoid labetalol because it is both alpha and beta blocker, and therefore we don't want to block alpha. We don't want to produce peripheral ischemia. Steroids, for example, high doses of steroid, especially dexamethasone, can suppress release of thyroid hormone from the gland immediately. And therefore, in thyroid storm, you must have seen patients are given dexamethasone in stress doses, which immediately suppresses the release of new thyroid hormone into circulation. Also, it helps to decrease the conversion of T4 to T3. And in long-standing chronic thyrotoxicosis, emaciated, hypercatabolic, there is usually decreased reserve of adrenal hormones in the adrenal gland. And therefore, in the emergency, steroids are useful for so-called functional hypoadrenalism. Cholestyramine is a drug which is useful in thyrotoxicosis. I have not used it, but cholestyramin's action is very interesting. What it does, it decreases the absorption of bile acids. And normally in thyrotoxicosis, lot of thyroxine is secreted bound to bile in the gut. And there is enterohepatic recirculation of the thyroid hormone. And that is blocked by cholestyramine, causing loss of thyroid hormone through feces up to 30%. So it's a interesting mode of action, but it takes longer time to make the patient euthyroid in this way. But if patient is allergic to neomercazole or methimazole, carbimazole, where you cannot this thing, and younger patient is allergic, cannot be advised radioactive also, iodine, or patient is not ready for surgery, then you can use definitely cholestyramine. I also used Telepac, which was a dye previously used for cholecystography, and that dye is very rich in iodine, and it can immediately suppress the release of thyroid hormones and can be used in patients who are not tolerant to ATDs.
Okay. So, sir has already summarized all the drugs that we use for preoperative preparation of hyperthyroidism. And calcium channel blockers can be used in those who do not tolerate beta blockers. So basically, all elective surgical procedures should be postponed till the patient is rendered chemically and clinically euthyroid, that is 6 to 8 weeks. The T3, T4 levels should be normal. There should be no resting tachycardia. And antithyroid medications and beta blockers are continued till the morning of surgery. If it is an emergency surgery and the euthyroid state has not been achieved, or if subclinical hyperthyroidism progresses without adequate treatment, then we can use a fast-acting beta blocker and infusion like esmolol, 50 to 500 microgram per kg, titrated in titrated doses, assuming the absence of heart failure. And for such patients, there should be a perioperative good monitoring of hemodynamics. So placement of arterial line or central venous pressure monitor should be considered. So do you want to comment on emergency surgery?
if there is going to be emergency surgery in an uncontrolled thyrotoxicosis, you have correctly pointed out that beta blockade is the most important thing to be taken care of. But you can simultaneously, if patient is not yet treated and not yet decompensated much to go into thyrotoxic crisis, then you should start methimazole as early as possible. It starts acting in 24 to 48 hours. Though actual complete action may take 2 to 3 weeks, at least action starts. So that can be done. And mainly good supportive care in the operating theater. You can you can tide over these crises nowadays, and there's nothing much to worry. If there is emergency surgery which cannot be avoided.
Right. Because of an increased incidence of myasthenia gravis in Graves' disease, a peripheral nerve stimulator is used to guide judicious administration of muscle relaxants. Thyroid storm or crisis still occurs in uncontrolled hyperthyroid patients as a result of triggers such as surgery, infection, or trauma. It is characterized by hyperthermia or pyrexia, tachycardia, and striking alterations in consciousness, which may be missed if patient is under general anesthesia. So its clinical appearance is similar to other differential diagnoses like malignant hyperthermia, pheochromocytoma, or neuroleptic malignant syndrome, further complicating the diagnosis. Mainly, it is based on management it is supportive management. So hydration, cooling, use of inotropes, steroids, and beta blockers and antithyroid drugs are used as the first line treatment. So one question I wanted to ask is, we usually, whenever we suspect that a patient might develop thyroid storm, like say uncontrolled hyperthyroidism going for emergency surgery, it is our practice to insert a rice tube during general anesthesia so that antithyroid medications can be given through it. So what do you think? How beneficial is the administration of antithyroid medications through a rice tube during intraoperative thyroid storm? How much time does a single dose take to bring effect?
We usually give nearly 5 times the dose, which is called a loading dose. For example, methimazole is given in 60 milligram loading dose, followed by 20 milligram TID, and then slowly 10 milligram TID ideal dose. But as I said, methimazole is rapidly acting, and within 24 hours, its action can be demonstrated. It takes about 1 week to develop full action, and it takes 2 to 3 weeks to develop full control of euthyroid, full control to the euthyroid state. So it is good practice that if you suspect a patient or diagnose a patient thyrotoxic, not yet on any treatment, then you should start the treatment in high doses in the beginning and continue it after the surgery also. That is good.
Coming to hypothyroidism, as we all know, the clinical manifestations of hypothyroidism, which have significant implications for an anesthesiologist, include depressed myocardial function, impaired baroreceptor reflex mechanisms, depressed ventilatory drive, decreased plasma and RBC volume, hypoglycemia, and impaired hepatic metabolism. So, hypothyroidism has been associated with a diminished cardiac output of up to 30 to 50%. Their deficiency of thyroid hormones causes an increase in the peripheral vascular resistance, resulting in an increased cardiac afterload, leading to a decreased pulse pressure via an increase in diastolic pressure and a decrease in systolic pressure. Patients with established hypothyroidism have a decreased metabolic rate and a decreased capacity to metabolize the drugs, which can prolong the recovery from the effects of anesthetic agents. Thyroxine is usually administered in a titrated manner to normalize the thyroid function, because preoperative higher levels of exogenous hormones can cause perioperative cardiac complications such as ischemia or infarction. Even though catecholamine levels are increased in these patients, they have a predisposition to develop hypotension under anesthesia, likely due to the downregulation of beta adrenergic receptors, because of which they might be refractory to the inotropic agents. In addition to cardiovascular concerns, hypothyroid patients face additional challenges due to ventilatory dysfunction and renal manifestations associated with this condition. So pleural effusions, respiratory muscle weakness, along with impaired hypoxic and hypercapnic respiratory drive and increased prevalence of obstructive sleep apnea, may complicate their perioperative management, as may a predisposition to pneumonia and atelectasis. Generalized edema may present a challenge to securing airway. Patients are at risk of developing aspiration due to delayed gastric emptying and altered mental status, and patients are exquisitely sensitive to sedating medications. So other abnormalities are anemia and electrolyte abnormalities, especially hyponatremia. Volume status has to be assessed carefully, because hypothyroidism leads to fluid shifts into the extravascular space due to increases in capillary permeability, leaving the patients with decreased intravascular volume. So it is recommended that prior to proceeding with elective surgery, patient should be euthyroid based on laboratory data and clinical evidence, and patients are typically treated with levothyroxine and rarely with leothyronine. So I would like to ask our expert, for a newly diagnosed hypothyroid who is posted for an elective surgery, How do you begin the treatment?
Actually, if patient is less than 40-year-old, we start with the full formal dose, that is 1.6 microgram per kilogram. Ideally, in adult patient, if TSH is more than 100, we start with 100 micrograms. It is only in patients who are having some ischemic heart disease or patients who are more than 40 years having hypertension or some other comorbidity that you can start giving slow or build up the dose by giving 25 microgram increment every weekly or so. But the ultimately dose is achieved to maintain the TSH levels between 1 to 5. If patient's TSH values are maintained, then is taken as euthyroid, and then this patient can be posted for surgery. If a patient is having some emergency surgery problem and his T3, T4 are normal, but TSH is slightly elevated, qualifying subclinical hypothyroid state, then even then these patients are taken as fit for surgery. I mean, just because patient is having slight elevation of TSH, you should not reject the patient, because many studies have shown that there is no much effect of slightly high TSH on the outcome of the patient from the surgery as well as many other complications. So it is the T4 level which is more important in hypothyroid patients. And if T4 is normal, TSH is slightly high, subclinical hypothyroidism, then most of the surgeries can be advised. There are patients who got angina, needed angioplasties, or even cardiac bypass surgery, and who are for the first time diagnosed to have hypothyroid. Such patients have been operated even without supplementing thyroid and have not shown to increase mortality. So somehow patients can be operated in hypothyroid state also. With such a good care of anesthesia which you all people are providing, I don't think there is any problem with hypothyroid patients. Patient is actually in mixed edema coma or something like that, then that is different situation.
Okay. Once we start the treatment for a hypothyroid patient, what is the time that is required for the TSH to normalize? I'm asking this because many times we are faced with the dilemma that the patient comes for preoperative fitness from the anesthetist, and that time probably the T3, T4 TSH is asked for the first time due to some indication, and then the TSH is very high. Medicine department starts their medication, and then the question is when to ask them to come back. So is it 6 weeks? Is it 8 weeks? Is it 4 weeks? Is there any such cutoff when we should ask them to come back for the repeat test?
12 weeks. For a frank hypothyroid to become euthyroid, it takes 3 months. Subclinical hypothyroid, you can call early 8 weeks or so. But otherwise, you should give sufficient time, because thyroid hormone has got different actions in different, you can say, organs, and it takes longer time. And ultimately, it is the biochemical euthyroid state which is achieved, and patient becomes fully like a normal person. It is by end of 3rd month or so. So by 12 weeks, you should call the patients.
So the pathophysiologic changes associated with hypothyroidism are generally reversible with replacement of thyroid hormone. And hence for elective surgery, it is better to have the patient euthyroid rather than facing the risk of acute decompensation. So in many of our preoperative guidelines, it is generally said that TSH should be less than 10 for a patient to be taken for elective surgery. So what is your take on this?
That is what we were saying, that is subclinical hypothyroidism. That's T3, T4 is normal, only TSH is slightly abnormal. It is allowed up to be, up to 10, it is allowed to take for any elective surgery.
Okay. In your experience, how common is mixed edema coma?
It's quite rare. Many times, nowadays people are being diagnosed like this. People go to gynecologist, people go to pediatrician, people go to orthopedician. Everybody keeps on doing T3, T4, TSH. People nowadays come to me with 50, 60 tests done without any reason, routine checkup.
Packages.
So there is a, you can say, tremendous amount of diagnosis going on. With minimum elevation of TSH, people make it underline and show that this is going up, going down, start some treatment. So it takes about, you can say, Uday, what was your question? How common is mixed edema? So in other words, there is a good evidence to say that nowadays mixed edema coma has decreased very much. It is very rare. In fact, when I started practice, I remember only 2 to 3 cases which we saw in first 5 years or so. And now last 10, 15 years, I have not seen a single patient of mixed edema coma.
Okay.
So yesterday only I got a patient for about 45-year-old or so. frankly hypothyroid, myxedematus, cannot speak normally, has got hoarse voice, cannot remember things easily, cannot understand fully what is going on. Unfortunately, in today's situation also, he has not been diagnosed, he has not been treated, but he has not gone into coma. I started him on treatment in slowly incremental fashion and have called him back after 3
What was
months.
the TSH?
TSH was 236.
Okay.
So interestingly, I don't think coma is very common these days, and it's unlikely that you will see in a operating theater.
Right.
The thyrotoxic crisis, you can precipitate the crisis during surgery or immediately after surgery. Post-operative fulminant course can be there. But myxedematis patient, before they come to you, if they are not treated, they will slowly be deteriorating. So by the time they reach you and you diagnose it, it is unlikely that you allow them to go
Right.
into surgery.
Right. So the next question is again the same. So if the patient is posted for cardiac revascularization, we have a fear that the thyroid replacement therapy might precipitate ischemia. So should these patients be posted directly for the surgery without
Should be
thyroid
posted for
replacement?
surgery because starting, as you said, starting treatment may increase the metabolism of the heart and muscles, therefore may precipitate angina. So best is he's stable at present, go ahead, do the surgery. And after surgery, you can start thyroxine.
Right. And what is the role of perioperative steroids in hypothyroid patients? So basically, do you advise giving steroids as what we call steroid cover for every patient who is hypothyroid during
No, no,
surgery?
no. Not at all. Nobody requires steroid cover unless you suspect clinically Addison's disease. Addison's disease occurs along with hypothyroidism in polyglandular autoimmune syndromes. That is, this is a combination of patient has got autoimmune thyroiditis presenting as hypothyroidism, autoimmune adrenalitis presenting as Addison's disease, associated with type 1 diabetes, and sometimes hypoparathyroidism. So such patients are there. They're quite common. Second is Sheehan syndrome. Previously patients used to come in PPH, failure of lactation, absence of menses after the delivery. Such patients are pituitary failure or pituitary damage, and therefore they have 2, 3, you can say, gland dysfunction and Addison's or hypocortisolemia as part of that. In myxedema coma, because patient is in a prolonged catabolic state or rather poor metabolic state, the adrenals have poor functioning going on. And therefore, in such patients, giving only thyroxine can precipitate them into Addisonian crisis. Therefore, it is advised that you support steroid in stress doses for a myxedematous coma patient, not for everybody, not for every hypothyroid. No problem.
Okay. So this is just one query. Some articles say that because T4 has a long half-life, it can be missed on the day of surgery, and some say that it should be continued on the day of surgery. So what is your advice?
It should be
Should we
missed.
continue or discontinue?
No, you should discontinue on the day of surgery. It can be restarted within 2 to 3 days, anytime, whenever you feel. Because the half-life is 7 to 14 days. And therefore, 1 week, if patient misses, doesn't happen anything.
Okay. So as we saw in severe hypothyroidism, the combination of intravenous T3 and T4 is recommended for preoperative myxedema coma management. And if possible, we should avoid premedication and use regional anesthesia. Preventive measures should be adopted to protect against hypothermia. And in those who require hydrocortisone cover, that should be provided. If emergency surgery is required, thyroid hormone levels should be normalized as rapidly as possible using IV levothyroxine in a loading dose of 200 to 500 microgram, followed by 50 to 100 microgram IV daily. Simultaneous IV T3 might be required if there is a suspicion of myxedema coma. And if there is a suspicion of concurrent adrenal insufficiency, glucocorticoids should be administered. In a subset of patients with hypothyroidism and anginal symptoms requiring
IV preparations are not available in India. We don't have
Okay.
IV thyroxine, not T3. But oral T3 has become available in last 6 months or so. In a patient suspected to have myxedema coma, we give a loading dose orally up to 600 to 800 micrograms of thyroxine only. Now, this loading dose actually is given to saturate all the binding sites on the thyroid binding globulin, so that the next dose after the loading dose gives more free T4, which then is converted in the tissues depending upon their requirement and deiodinase levels into the required amount of T3. So people still argue that there is no need to give IV T3 in such patients. Let the body convert the available free T4 into T3. So
Okay.
that is one thing. And there are some trials available which show no added advantage of giving T3 to such patients.
Okay. So like we discussed, thyroid hormone may not be given in patients in whom and ischemia may be precipitated before revascularization. Hypothyroidism can be a part of polyglandular autoimmune syndrome, like Sir said, primary hypothyroidism, Addison's disease, and type 1 diabetes. In suspected myxedema coma, because of prolonged hypometabolic state, patients have decreased adrenal reserve. So they are treated with steroids before starting thyroxine. And once the patient is out of coma, they are investigated for presence of Addison's disease. In hypothyroidism, body heat mechanisms are inadequate, and so temperature should be monitored and maintained, especially in patients who are taken for emergency surgery. Coming to the last part of our session, what are the chances of post-operative hypocalcemia after thyroid surgery, and what can be done to prevent it or treat it?
Actually, if thyroid surgery is only lobectomy, etc., then usually hypocalcemia is not expected. But in subtotal thyroidectomies or total thyroidectomies, there are very high chances, nearly 40-50% chances of developing hypocalcemia. So ideally, you should get a calcium level done within half an hour of thyroid surgery. And if it is low, because calcium half-life is only 10 minutes or so, you can diagnose hypocalcemia developing in 20 minutes or so. So if it is low, even PTHSA can be done immediately after surgery. Then you should start such patients on IV calcium gluconate till they start recovery and start taking oral calcium supplements. I think, Ketki, we have to stop because already we are 40 minutes now.
Yes,
And
yes, this is the end of the session. So
yeah.
thank you, sir, for the enlightenment. I'm stopping the sharing of the screen, and I will introduce our next speakers. So Dr. Vijay Patil is the professor of anesthesiology and head of department of anesthesiology at Rajiv Gandhi Medical College. And Dr. Anmol Lalwani, she is the associate professor of anesthesiology at Rajiv Gandhi Medical College. I invite Dr. Anmol to share their screen and start with diabetes and anesthesia.
Oh, okay. This is keep on. अपने में क्लिक करना अपने डिस्प्ले फिर वापस वही हमें स्लाइड शो करना कैसे है
क्या करो
क्या था अपने एस्केप करेंगे आप अपने में जाओ अपने में क्लिक करेंगे स्टार्ट वीडियो शेयर स्क्रीन हो रहा है
वहाँ वो ऑप्शन नहीं क्या लास्ट पे फुल स्क्रीन का
शेअर स्क्रीन केलंस का
बस
Yes, madam.
Can you see?
Slide show click करो from beginning.
from beginning
हाँ
we can see
Okay, good evening, everyone. I will be talking on the diabetes. It's the most commonest endocrine disorder, and the incidence as per the ICMR Diabetic Society in 2020 is 10 crores. And for anesthetists, the incidence of the cases coming for the emergency as well as elective cases is very high. So this is a very common disease, and everybody knows most of the protocols. And this disease affects almost all the system. And when we take the patient for the surgery, we ask the very detailed investigations But we are not going to discuss everything. Today we'll be only concentrating on the two aspects. One is we have a dilemma with the glycosylated hemoglobin, and other is a part of the autonomic neuropathy, which is CAN, is a cardiac autonomic neuropathy. So we'll be talking on that. So first, we'll talk about the cardiac autonomic neuropathy. Why I've chosen this topic? Now, almost for 20 years, I'm practicing the anesthesia. And then I have not come across a single case which has been still a diagnosed case of autonomic neuropathy. I'm aware of the cardiac autonomic neuropathy and myself now documented it. And over the period, I come across the literature which shows the cardiac autonomic neuropathy is associated with a lot of morbidity and mortality in the perioperative period. So we are not using this as a risk stratification. And every now and then we are having an incidence, in a perioperative period, suddenly some events has happened. And I wonder, whether we are missing out some of the explanation. So this is complete autonomic neuropathy is quite a big. So to be precise, we'll be talking only about the cardiac autonomic neuropathy. So it's very simple because it's only deal with the heart rate and the blood pressure. So all anesthetists will be comfortable with. I think the slide is. Yeah. So definition of cardiac autonomic neuropathy is defined as an impairment of autonomic control of the cardiovascular system in a setting of diabetes after exclusion of other causes. CAN is usually documented using several cardiovascular autonomic reflex tests. Now, prevalence of the CAN is quite common. It prevalence increases with the duration of the disease and as well as the control of the disease. Longer the duration, more common is the CAN. Now, just to be aware of with the CAN, what are the abnormalities we see in the CAN, clinical manifestation of the CAN? So we are divided into two parts. One is a cardiovascular system and one is a clinical manifestation in a peripheral vascular system. In the cardiovascular system, I again try to divide it into two, which are very commonly we can diagnose, something like a resting tachycardia, hypertension, QT interval prolongation. These are the things which we can definitely, during the PSC, we definitely able to point out. Then there are certain things like exercise intolerance. Exercise intolerance, especially if there is no evidence of any cardiorespiratory disease and patient complaint of the exercise intolerance, then it's significant. Probably it is a one indication. Orthostatic hypotension and silent myocardial ischemia. Silent myocardial ischemia is many times we see the patient's ECG, which suggests diabetic patient comes with the ECG finding suggestive of old MI and doesn't give the history. And sometimes patient himself gives a history, but then he says there is no chest complaint when the event has occurred. So these are the patients for a silent myocardial. So and we can easily pick up. And the other manifestations, which are for anesthesia, little difficult to pick up, because in a PSC setting, the left ventricular dysfunction, hypertrophy, impaired baroreflex sensitivity, non-dipping and reverse dipping, and postural hypotension. Now, non-dipping and reverse dipping, this is a very simple thing, it's a blood pressure measurement. When person sleeps, that time the blood pressure should go down, and the person in which this phenomenon is not seen, we call him a non-dipping. Whereas the reverse dipping, it's like sometimes you see the increase in the blood pressures. And postprandial hypotension, these are very difficult to diagnose. Sympathetic vagal imbalance, dysregulation of cerebral circulations, decreased sympathetically mediated vasodilatation or coronary vessels, and increased arterial stiffness. Now, the peripheral manifestation, again, there are few which we can definitely pick up in a PSCs. Increased peripheral blood flow and warm skin, increased arteriovenous shunting and swollen veins, increased venous pressure, leg and foot edema, loss of protective cutaneous vasomotor reflexes, loss of veno-arterial reflex with the microvascular damages, increased transcapillary leakage and micromolecules and medial arterial. This sounds a little boring, but then I try to make it a big article in a small. Now, this is again CAN and nephropathy. The nephropathy is very much commonly associated with the CAN, and the article says the CAN and autonomic pupillary abnormalities independently predicts the progression of diabetic nephropathy. And CAN mediated these changes because of the changes in the glomerular hemodynamics and circadian rhythm of the blood pressures. Also, the patient can have erythropoietin deficiency anemia, as the CAN is known to disrupt the dysregulation of the erythropoietin production. Now, an assessment, like any other clinical entity, we have to assessment with the symptoms and with the signs. About the assessment with the symptoms, there is no standardization because those symptoms are little difficult to standardize. There's no questionnaire available, but the signs are very simple, like tachycardia. It is a resting tachycardia. It's maybe because of the increased sympathetic tone or decreased parasympathetic tone or vagal pathology. Exercise intolerance, orthostatic hypotension, prolonged QT interval. This again has to be rate adjusted. There are multifactorial reasons for this prolonged QT intervention, but when the CAN is there, probably the impairment of the sympathetic innervation is the reason. Again, dipping and non-dipping. Now, how we assess this CAN? There are simple tests, what we call as a cardiovascular autonomic reflex test. The CART assesses the cardiovascular autonomic function through the provocative physiological maneuver and by measuring the end organ response, that is heart rate and blood pressure changes. Although the indirect autonomic measures, they are considered as a gold standard in autonomic testing. So heart rate test, heart rate variations during the deep breathing, Valsalva maneuver, and lying to standing position. This indices predominantly the parasympathetic functions. The cardiovascular autonomic reflex test for orthostatic hypotension, blood pressure response to the Valsalva maneuver, and sustained isometric muscle strength. This indices the sympathetic functions. So now there is a grading for this CAN. Only when there is only one heart rate test is positive, possibly early, but when the second or third heart rate test is positive, it's definitely a confirmed case. And when there is a severe orthostatic hypotension, it's a severe and advanced stage. And then another is symptomatic levels. So now, why we are not practicing this? Can I feel that within the next thing is come, there are confounding errors, when you do this test, and anesthetist is very well aware of with the interpretation of the heart rate and blood pressures. And this article has come up with a huge list of the confounding errors, that is standardization, patient compliance, age, respiratory, so on and on. So that is why but then again, I feel that we can definitely, when we know this, if the culture of symptoms are seen in the patient who is having a long-standing diabetes, then we can definitely pick up certain patient and we can do one or two tests. And even if the diagnosis is not precise, we label that patient as a case of CAN. Now, I would like to ask sir, in his clinical practice, how often he's seen cases of autonomic neuropathies and how they assess and whether they are documented. And another question is whether this autonomic neuropathy is reversible.
Baba, you are mute.
Am I audible? Hello?
Yes,
Sir.
Now we get patients with diabetic autonomic neuropathy called as DAN. One of the part is CAN, as you said. But as you rightly said, there are no clear-cut documented tests available, and we also do only orthostatic hypotension, resting tachycardia, loss of hair from the limbs, and then thin, cold parchment-like skin, some pupillary abnormalities, and symptom-wise, constipation, diarrhea alternating with each other, or urinary retention, and similar like finding. But usually, autonomic neuropathy, diabetic autonomic neuropathy, is not an isolated presentation. It always comes with peripheral neuropathy. So main presentation is with tingling, numbness, loss of sensation, diabetic foot, absence of the pressure points, getting corns and all. So it is mainly part of peripheral neuropathy investigation that we get nerve conduction studies, etc. And from that we presume that they also have cardiac autonomic neuropathy. Because main thing from our point of view is that autonomic neuropathy is very early to develop in type uncontrolled diabetes. And if it persists like that, it correlates with the future morbidity and mortality. But as you said, we don't document it separately. It has been studied in experimental papers, etc. But routinely we mainly concentrate on neuropathy. If you advise the patient good control, tight control, and if autonomic neuropathy has developed recently, then it is supposed to be completely reversible. So there is nothing to worry about autonomic neuropathy. It may come back. It is mainly the peripheral demyelinating neuropathy, which is irreversible. So once the damage done, it is done. Anyway, let us see what next.
For this is the article from which I taken this information. This is a single article. Now the next dilemma we face is whether we really need a glycosylated hemoglobin test for every diabetic patient going for elective surgery. So this topic arises because many times our patient didn't have, and we said go ahead, and then my juniors and my colleagues were not happy with that. So I decided to read about it, and we all know glycosylated hemoglobin gives the sugar level control of last 90 days, as it is a glycosylation of hemoglobin, and RBC has a lifespan of 90 days. So besides this, when I was searching for this literature, I come across many studies which say that higher glycosylated hemoglobins are associated with many mortality and morbidities and many peri-operative complications like the infections and all that. But I didn't come across there is any cutoff which has been prescribed for a pre-evaluation that okay, you have to have this much glycosylated hemoglobin levels. But then also when I see the diabetic patients coming with glycosylated hemoglobin reports, if it is coming in with a higher glycosylated hemoglobin, I can definitely predict that it might we might face the problem with the hyperglycemia in the intraoperative or perioperative period. Whereas if the diabetic patient on medication, which comes with a lower glycosylated hemoglobin, then probably I have to worry about the hypoglycemic episode that is more likely to happen. So here I will like to sir that how essential is the glycosylated hemoglobin to be done in perioperative testing.
It is very essential, If a patient comes to you, you don't know the patient, no history is available. Then you want to differentiate first whether this is stress hyperglycemia or patient is really diabetic. In stress hyperglycemia, the glycosylated hemoglobin will be normal. Only in the diabetic patient, it will be more than 7%. And if it is more than 9.5%, most of the guidelines will advise you to not take it for surgery, elective surgery.
Okay.
And most of the complications have been correlated, at least macrovascular complications have been correlated with glycosylated hemoglobin. So it is always better to get glycosylated hemoglobin.
Okay. Next topic will be covered by Anmol.
Good evening, everyone. So I'll be taking the topics ahead. So we will discuss a few concepts ahead, which are useful in our day-to-day practice. Okay. So we'll see about the variable glucose levels. These are the different glycemic targets in different diabetic patients. So diabetic patients who are chronically hyperglycemic, they can tolerate a higher normal blood sugar levels, and they have a reduced glycemic variability. In a non-diabetic patient who is chronically hyperglycemic, the organs and immune systems, they are accustomed to higher blood glucose concentrations. Any acute attempt at euglycemia in these patients, there will be a relative state of hypoglycemia for them. Okay, so we have different glycemic targets for different diabetic patients according to their regular HbA1c levels. There is a direct association between perioperative hyperglycemia and adverse clinical outcomes. That is, the risk for post-operative complications and mortality becomes very high. There are certain physiological changes like impaired neutrophil function, overproduction of reactive oxygen species, free fatty acids, and inflammatory mediators. They cause a direct cellular damage and vascular and immune dysfunctions in a hyperglycemic state. Okay. There are certain factors contributing to hyperglycemia, that is anatomical location of surgery. Extensive surgery will have a higher blood sugar levels. Invasive procedures are going to have a higher blood sugar levels as compared to laparoscopic surgeries. And then it also depends upon the intraoperative fluids that we administer and the pre-op nutritional support given to the patient. Surprisingly, general anesthesia is more frequently associated with hyperglycemia as compared to regional anesthesia because it really releases a lot of catecholamines and cortisol and glucagons. Okay. So, and also use of volatile anesthetics increases the glucose production and it inhibits the insulin secretions. So it also gives rise to hyperglycemia. Now we come upon the stress hyperglycemia, which sir has already described how to differentiate the stress hyperglycemia from a diabetic hyperglycemia. So we briefly see about how it is caused. So the stress of surgery and anesthesia, it alters the finely regulated balance between hepatic glucose production and glucose utilization in the peripheral tissues. So there is increase in the counter-regulatory hormones, that is catecholamines, cortisol, glucagon, and growth hormone. So cortisol increases the hepatic gluconeogenesis, glycogenolysis, and there is a lot of glucose output and it causes hyperglycemia. Whereas it also decreases the insulin production. Free fatty acids inhibit the glucose uptake in the skeletal muscles, which we call it as a relative insulin resistance, which also causes hyperglycemia. So this all happens during stress of surgery and anesthesia. So I think we will, and sir has already described how to differentiate between the diabetic hyperglycemia and the stress hyperglycemia. So we'll skip through. Okay, sir, is it fine?
Yeah, it's okay.
Okay. So we'll skip through this. So I wanted you to contribute on this pre-operative carbohydrate loading. Does this strategy counteract the stress hyperglycemia? What is your take on that?
Actually, this ERAS program, that is easy or early recovery after surgery,
Yes,
is going on for last 20 years or so or more slightly.
exactly.
And these people, advise that patients should be fit and in positive metabolism to avoid the catabolic processes. And they started advocating about 100 grams of carbohydrate on the night before surgery and 50 grams of carbohydrate just 2 hours before anesthesia. And they claim that this prevents the insulin resistance, etc. But whatever small studies they have done are mainly in non-diabetic patients. And there are as yet no clear-cut randomized controlled trials. There are no insulin clamp studies to show whether there is really any benefit. Because my feeling is if you load such a patient with 150 grams of carbohydrate, then you have to give at least 10 to 20 units of extra rapid-acting insulin to cover it. Because patient is diabetic, he's not going to produce more insulin because you are loading it. So peri-operative hyperglycemia, which we want to treat, we want to avoid, will be precipitated by ERAS program. So that needs to be, especially, in a long-standing diabetic. If patient is diabetic only for 2 years or so, maybe he may tolerate. But there's no clear-cut, guidelines about this in all, you can say, American diabetes or ESD guidelines. Nobody has stated anything even after so many years of, advocation. This mainly came from insurance studies. They want people should be staying in the hospital for minimum period of time. So how fast you can send the patient back? So in America, at least, it's the policy-driven, pharma-driven policies are there. So one of them is ERAS. So my personal feeling is in diabetic patients, this should not be tried. There is also chance of gastroparesis in these patients. So they may aspirate such fluid taken 2 hours before anesthesia.
Okay, sir.
We do not know what happens to, stress hormones, metabolic studies. Nothing has been done about it in diabetic patients. If you have found out anything, you can call. I don't know. Many times I learn from such new studies. I don't know.
Okay, sir. So we'll go ahead. I don't have much to contribute on this in diabetic patients. Yes, non-diabetic patients, it should be followed.
But do you follow it here?
No. We don't follow in our institute. We don't have proper guidelines to do that, and the surgeons also, we cannot convince them to give fluids before the surgery.
Similar situation arises when patient is on parenteral nutrition therapy and is going for surgery. There people have shown that extra amount of insulin is required to combat the stress of, and insulin resistance which increases during surgery. So I personally feel it may not pick up in diabetic patient at least.
Okay. So we go to hypoglycemia, where it is defined as the fasting blood sugar is less than 70 milligram per deciliter. It is usually a complication arising out of hyperglycemia treatment. Severe hyperglycemia is also defined as when the blood glucose level is less than 40 milligram per deciliter. The incidence of such events ranges anywhere between 5 to 28% in ICU settings. Okay, so we come up to the risk factors which patients can go into hypoglycemia. Mainly they are older age people, kidney failure, patients who have a change in nutritional intake, those who have an interruption in glucose monitoring, patients on previous insulin therapy, and who have a failure to adjust the therapy when the glucose is trending down or there is a steroid therapy being tapered. It is associated with prolonged QT intervals, ischemic changes, and angina, arrhythmias, and sudden death in patients is also seen in type 1 diabetes. We see about the controversies of the exact blood sugar levels which are acceptable by the patients by different societies. The Society of Ambulatory Anesthesia recommends intraoperative blood glucose levels of less than 180 milligram per deciliter, which is also followed by the Society of Thoracic Surgeons. The Endocrine Society recommends FBS less than 140, while RBS less than 180. The Joint British Diabetes Society proposes a little lower blood glucose levels, while American Diabetes Association, which we usually tend to follow, recommends the target blood glucose range of 80 to 180 milligram per deciliter in the peri-operative period. Okay. I would want Sir to contribute on this. What should we follow?
About, I think, 2002 or 3, when Vandenberg did the major studies about critically ill patients in surgical ICU, and there she showed that a tight control, that is 110 to 140, in most of the patients helped them to recover fast. At that time, at least, she did not report any excessive morbidity or mortality with such tight control. The next part of such study was medical ICUs. There it failed to show any improvement in the mortality. And third was to find out what is happening. Nice sugar study was done in which about 6,000 odd patients were included from multi-center point of view. And when they were studied, it was found that tighter the control, more the chances of hypoglycemia and more cardiac deaths. So since then, it has become all over the world as the accepted guideline that in all ICU settings, you maintain blood sugar between 140 to 180. In some situations where the cardiac surgeon especially want a little bit tighter control and where the team is trained to avoid hypoglycemia, you can go up to 110 to 140, but again with clause. So my feeling is we should take 140 to 180 as the accepted target blood sugar and follow that. There is no need to go very tight on controlling this.
Okay, sir. So next we see is a J-shaped mortality curve. This graph shows a J-shaped relationship between the blood glucose level and the risk of mortality, with the least mortality between 90 to 140 milligram per deciliter. But now in the patients with established diabetes mellitus, the relationship between hyperglycemia and mortality is significantly blunted, and it is somewhat shifted to the right side. So it means the diabetics tolerate higher blood glucose level better, and while they tolerate hypoglycemia worst. Okay. So now after looking at the J-shaped curve of blood glucose versus mortality, we see a few randomized controlled trials which establish a causal relationship between hyperglycemia and adverse outcomes. So we will describe the two studies over here, which were the landmark trials. This is a graph comparing both the studies. The first RCT was done to test the hypothesis that there is increased mortality with hyperglycemia. It was done in Leuven in Belgium, so it is called as a Leuven study. It compared the tight blood glucose control, what is described between 80 to 110 milligram percent blood sugar levels, to then normal glucose levels, that is 216 milligram percent, which was the renal threshold at that time. So that time it was considered as normal sugar levels. In the study population with tight glucose control, the mortality was less. But these hypotheses, as sir said, was tested in medical ICU setting, but it failed to show the similar results. So, and all these studies, similar studies were done, but they were all very small studies. So statistically underpowered studies were done. So NICE sugar study was done as a multicentric study, which revealed that targeting the blood sugar levels less than 108 milligram per deciliter with insulin increased the 90-day mortality. Whereas as compared to 140 to 180 group, the mortality was significantly less. So conclusively on all these trials, so we have come up to the acceptable blood sugar level at 140 to 180 milligram percent. Okay. So now we see about the preoperative preparation of the diabetic patient, which we normally do is like we schedule the patient early in the day. We recommend to check the blood glucose level in the pre-op area. Hypoglycemia is treated with dextrose solutions, and severe hyperglycemia if blood sugar is more than 250 or there is a metabolic decompensation. We optimize the patient and postpone the surgery by a couple of hours for better glycemic control. Yeah. So I would want sir to help us make the guidelines on oral hypoglycemic agents and insulin, what to hold and what to withhold. This is what we generally follow. But I want sir's input on this.
Okay, rule number 1 is stop all oral antidiabetic agents at least 24 hours before planned surgery. Especially SGLT2 should be stopped at least 48 hours before surgery, because there are lactic acidosis and euglycemic ketoacidosis. So there is no oral drug which should be allowed, nor the injectable GLP-1 receptor analogs should be allowed during surgery. Secondly, now you are planning to prepare the patient for surgery, so you have to do 3 steps. These 3 steps, one is called as TDD, that is total insulin requirement dose, daily dose of insulin. Now, how that is calculated? Supposing patient is 70 kg, then 0.55 units per kg for a you can say insulin sensitive person, and 1 unit per kg for insulin resistant patients. So most of the obese, centrally obese patients with acanthosis, type 2 diabetes, they are insulin resistant. So they will require higher doses of total daily insulin. Once you know what is the total daily dose requirement, then you divide that into 40 and 60%. So 40% will be given as basal, that is long acting, either NPH or Lantus or Glargine. And remaining 60% will be given as prandial or bolus doses of rapid acting insulin. Here what we do is we try to calculate carbohydrate coverage ratio. Now you have got total daily dose requirement you already found out. Supposing a 70 kg man who is supposed to be insulin sensitive, then 0.55 unit per kg means about 38 point something units of insulin is his actual total daily insulin requirement. Now 500 divided by the total daily dose gives you carbohydrate coverage ratio. That means here if I taken that example, 500 divided by 38.5 gives a figure of 12.9. That means 1 unit of insulin in this patient will cover the 12 grams of carbohydrate in his diet. You follow this? Now this will be useful for even dextrose drip, because dextrose drip will be 5% dextrose is 5 grams per 100. So 1 pint is equal to 25 grams. So here you will need 2 units of insulin in this patient apart from basal coverage to cover each 5% dextrose 500 cc. But usually patient being insulin resistant, we increase the dose to double, that is 4 units given per 500 cc of cc. Then third thing you calculate is called as sugar correction factor. Apart from basal and bolus, you need to know what is correction dose. Supposing now you are going to give the insulin, you have decided that this patient requires a 40% of the original requirement, say about 12 or 15 units as the Lantus, and remaining you have to plan to give as Actrapid or rapid acting insulin. Then how do you calculate that? I have told you from carbohydrate requirement. And now third factor comes in is called as correction. Now when you are going to give the insulin, you see the blood sugar. Now here your target blood sugar, as we said, is 140 to 180. So 140 should be pre-meal and 180 should be maximum post-meal. So if 140 is target and patient has say 240 blood sugar at the time of giving the insulin, then 240 minus 140 is 100, isn't it? Now that has to be taken care of. So that is taken care of by another ratio called as sugar correction factor. That is 1800 divided by total daily dose. So 1800 divided by 38 is equal to 46. That means each 1 unit of extra insulin will reduce the blood sugar by 46 milligrams. So here blood sugar is more by 100 milligram before you start treatment. So you give extra 2.5 or 3 units of insulin. So you have calculated the dose from his calorie consumption or dextrose drip, and you have calculated the correction dose. So that together is taken as the dose for the bolus or prandial dose. So now you have the equilibrium that say 40 units of insulin is to be given. So you give 20 units as the basal dose. And then with each dextrose drip or with each meal which patient can consume, you will add according to the sugar content, the primary dose, and according to the sugar content at that time, correction dose. Now, this will go on for most of the patients who need surgery which lasts for less than 4 hours. But if surgery is going to last for more than 4 hours, then patients may need insulin infusion. For that, different calculations are there. Or type 1 diabetes is there. You need insulin infusion in such patients. So not to make more complicated, I again come back to original 3 equations which you all of you should know. One is finding out total daily dose requirement. Then 500 divided by total daily dose requirement gives you carbohydrate coverage dose. That is 1 unit of insulin will take care of so many carbohydrate grams. And third is correction dose. That is 1800 divided by the total daily dose. In this patient, 1 unit is going to take care of so much amount of blood sugar which is extra. So from that you would say correcting dose. So now you can fairly manage most of the patients with this background.
So this all insulin will be subcutaneous or IV, what we are going to give.
And as I said, if surgery is going to last for only less than 4 hours, then subcut insulin and 2 hourly blood sugar glucometer point of care measurement is okay. But if surgery is going to last for more than 4 hours, then you are going to put IV insulin drip. And for that, every half to 1 hour, glucometer readings will have to be done so as to adjust the correcting doses.
So in the perioperative area, subcute absorption of insulin, is it reliable? Because
Depends.
we in
If
our
patient is in
OT,
shock, patient is, okay, go ahead.
because in our OT, the temperature is very low. So there is vasoconstriction in the skin. And there are a lot of other factors that's fluctuating hemodynamics. So is it reliable?
I personally don't find any reason why it should not be reliable, because as long as BP is normal, body is taking care of AC, you know how to combat AC. There is a thermostat inside. So that should, but if a patient is really hypotensive, septicemic, then as you said, subcut doses may not be
Will not
absorbed.
work.
And
So we
then
will have to go for IV. The same calculation will work for IV dosage as well?
for IV doses, we start with basic presumption that the person will require 2 units per hour.
Okay.
And now you have to only need correction doses. So you start a drip 1 unit per ml and then adjust the micro drip to give the 2 units per hour as the basic dose. And now if patient's sugar is at 240, just like that what we did for the correction dose, then 40 units are extra. So you need to increase 1 unit. If it is more by 90, you need to increase. So the rate becomes 3 units or 4 units depending upon the sugar.
Okay. Okay. So we go ahead. This is what the basics are told. It is given in the table. So what we do is manage accordingly the insulin sensitive, usual sensitive, and resistant patients. Now we see about the sliding scale, which is concepts and misconceptions. It is a little bit of history of insulin. Insulin was discovered by Banting and Best in 1921. In 1937, we saw the evolution of modified insulin, which was given to the patient 2 to 4 times per day. But usually it was observed that overtreatment could result in significant toxicity and conversions due to severe hypoglycemia. So this led to monitoring of the blood glucose levels before administration of insulin. So first 50 years of insulin therapy, the clinicians recommended giving regular insulin according to the amount of glycosuria. So Eliot Jocelyn in 1934 gave us the first early algorithm for use of insulin versus urinary glucose. The blood glucose monitoring was available only in the hospitals, which was cumbersome and needed large volumes of blood. So the introduction of capillary glucose monitoring led to the birth of sliding scale insulin. This was the initial very old sliding scale regimen, which was widely accepted by the medical fraternity at that time. Despite the simplicity and convenience of sliding scale insulin regimen, not a single study has shown improvement in the glycemic control or clinical outcomes. So sliding scale insulin was considered as a very reactive method of glycemic control that was not ideal for the long-term treatment of the patients because of potential of hyperglycemic or hypoglycemic episodes. Hence, the use of sliding scale insulin could be considered as one of the popular medical myths. Since last 5 decades, several editorials and original articles have discouraged its use, and as elegantly indicated in 1963 editorial titled, "Let's get the sliding scale out of medicine." So how should we use the insulin to the maximum benefit in such cases?
This sliding scale was failure because there was no basal insulin incorporated in the regime. It was a highly variable glucose levels, which were more damaging to the microcirculation than a persistent high level. But with the availability of basal bolus regime now, we are similarly following a modified sliding scale only. But we take care that patient will have a minimum amount of insulin always in the circulation. So it will not allow the blood sugar to go to beyond certain range. And we also take care of intermittent hyperglycemic peaks, which will occur by correcting doses. So this type of sliding scale nowadays is accepted all over the world. And though we do not use the word sliding scale, so that we should not remind our colleagues to use urine glucose monitoring. But we are doing the same.
Okay, sir. So this is one of the usual insulin regimes which you have described briefly we are using. So now we come to the last guidelines. These are the CPOC guidelines. They are given by the Center of Peri-operative Care for the people of diabetes mellitus undergoing elective or emergency surgeries, updated in December 22. This is usually the routine we consider, just the concluding part of the session now. So factors to consider in the peri-operative management of diabetes is type of diabetes, long-term management of diabetes, urgency of the procedure, degree of metabolic derangement on presentation, anticipated period of total fasting. Perioperative blood glucose targets should be done by capillary blood glucose monitoring in the pre-op period. The target should be around 106 to 180 milligram per deciliter. 216 may be acceptable. In non-diabetics, lowest acceptable of the blood glucose is 106 milligram per deciliter, while in awake non-diabetic patients, 72 milligram per deciliter is also safe. We should monitor the patients if are on hourly basis, if they are on variable rate IV insulin infusions, especially if sedated or anesthetized. So last slide is this Nadia Harms 2020 slide. It recommends to optimize the surgical pathway by proper identification and referral of diabetic patients and aiming for avoidance of metabolic derangements. So we have to prepare a standardized perioperative care protocol for these patients so that there is a limited hospital admission. We should promote ambulatory surgical treatment. And we should prevent the potential of reducing, we should prevent the iatrogenic harm in such patients, such as insulin administration errors. But even after discharging the patient after ambulatory surgery, diabetes mellitus still remains a risk factor for readmission after ambulatory surgery. Okay. So, sir, do you want to add something?
No, nothing. I think we are already 5 minutes over, but it was okay. Well in time.
I would want to introduce our next speaker, Dr. Radhika. She has been with us for 3 years as a lecturer in anesthesia. I will share her screen. Is the screen visible? Is the slide share visible? Or I am visible?
You are visible.
Dr. Radhika, you need to unmute yourself and start your video.
Yes, we will do that, ma'am.
Yes, now it has gotten shared.
Yeah. So this is Dr. Radhika for you. Am I visible and audible?
Yes.
Yes.
Yeah. Good evening to one and all. I'm Dr. Radhika Ganesh, currently working as Assistant Professor in RGMC Kalwa in the Department of Anaesthesiology. Today, I'll be discussing a case presentation on pheochromocytoma under the guidance of Dr. Milind Patwardhan sir. So my case is a 34-year-old female who presented with 6 months history of recurrent episodes of palpitations, chest pain, sweating, headache, and nervousness. She was referred from a peripheral hospital as a case of right adrenal mass lesion, which was shown on CT abdomen. Her USG abdomen showed a well-defined encapsulated mass in the right suprarenal gland with heterogeneous ecocity with separated feeding artery. And the CT scan revealed a right adrenal mass causing downward displacement of the kidney. Her pre-anesthetic checkup was done as follows. On taking the history, there was no history suggestive of any comorbidities like hypertension, diabetes, or IHD. On examination, her pulse was 64 beats per minute and BP was 110 by 70 millimeters of mercury. There was no other positive systemic findings and all the baseline investigations were normal. The patient was started on tablet prazosin 2 mg BD 6 days before surgery. All her baseline investigations were done, most of which were normal, except for urinary metanephrine levels, which were high. So the diagnosis was made as a case of symptomatic pheochromocytoma who was posted for resection of tumor under ASA grade 2. So coming to the case discussion of pheochromocytoma, it usually affects 0.01 to 0.1% of population who are hypertensive, and it is found in 0.5% of the people who are screened. The male to female ratio is usually equal, and it usually occurs in the third to fifth decade of life. As it is a rare phenomenon, you need to investigate the condition only if clinically suspicious, which includes signs and symptoms, severe hypertension, refractory hypertension to more than 3 drugs, or hypertension present at age less than 20 or more than 50 years, and there is a suspicious adrenal lesion which is found on imaging. So pheochromocytoma usually follows a rule of 10, in which 10% of it is extraadrenal, 10% occurs in children, 10% is familial, 10% bilateral, recurrent, malignant, and 10% is discovered incidentally. We come to the signs and symptoms, which comprises of 5 P's, namely pressure, that is hypertension, pain, that is usually manifested as headache, perspiration, palpitation, and pallor. The symptoms are usually paroxysmal. So we can describe a classical triad to diagnose any pheochromocytoma, which is pain, usually headache, perspiration, and palpitations. Lack of all 3 virtually excludes the diagnosis of pheochromocytoma. So what are these paroxysms or spells exactly? They are usually occur in a frequency of daily to monthly basis and usually 10 to 60 minutes in duration. They can be spontaneous or well as precipitated by various procedures like diagnostic procedures, certain drugs like opioids, histamine, metoclopramide, glucagon, any strenuous exercise, and movements that increase the intra-abdominal pressure. As bladder paraganglionoma can also be present in certain clinical scenarios, micturition can also accelerate these paroxysms or spells. So there are some rare phenomena in which there is hypotension in case of pheochromocytoma. The mechanisms usually include a lot of ECF volume contraction due to prolonged vasoconstriction, loss of postural reflexes, and tumor release of some other hormone, namely adrenomedulin. So at this stage, I would like to ask the expert whether he has seen any rare clinical phenomenon in which the symptoms are different as usually described in case of pheochromocytoma.
Actually, we have seen many pheochromocytomas. We have seen about half a dozen of bilateral pheochromocytomas. Interestingly, our patients, only 50% or so presented with classical triad, Others were detected because of either resistant hypertension or because of incidentally detected adrenal mass. Many of the patients, interestingly, also were, previously started on beta blockers. Normally, we believe that beta blockers are totally contraindicated unless you do alpha blockade. But those patients who were in, general population, they were being seen by general practitioners, and as a first-line treatment, they were started on beta blockers. And interestingly, nothing had occurred, of course. But they came for follow-up when we stopped beta blockade, gave them alpha blockade. And interesting thing is about 10 to 20% may not have hypertension at all. But if you have proved that there is excess catecholamine excretion or catecholamine synthesis secretion, then even if blood pressure is normal, I think that was the case in your also. The patient was normal when you showed us the slide 130 or 110/70.
Yes.
But alpha blockade has to be done for all patients, whether they are hypertensive or not.
Okay. Proceeding, the various signs and symptoms which can be seen in a patient of pheochromocytoma are nausea, vomiting, abdominal pain, constipation, chest pain, anxiety, and catecholamine-induced increased myocardial oxygen consumption, which leads to coronary vasospasm. The patient can also present with congestive heart failure or cardiomyopathy. Now, in case of pheochromocytoma, hypertrophic as well as dilated cardiomyopathy can be seen. Hypertrophic cardiomyopathy is mainly because of catecholamine-induced prolonged hypertension, thereby leading to hypertrophic cardiomyopathy. It can also lead to dilated cardiomyopathy as all the catecholamines cause a change in the sarcolemmal membrane, causing increased influx of calcium, thereby leading to permeability changes and thereby leading to dilated cardiomyopathy. We can also have patients with cardiac dysarrhythmias and conduction defects. There can also be various metabolic signs like hypercalcemia, which is usually associated with MEN2 syndrome, mild glucose intolerance, and lipolysis. So the various investigations that are usually advised in a patient with pheochromocytoma are 24-hour urine collection to look for catecholamines, metanephrines, VMA, or dopamine. And HPLC can also be done with electrochemical detection or mass spectrometry. Usually, positive results indicate more than 2 to 3-fold elevation of all these levels. The normal range of each of these levels are as follows, which can be seen in the slide. We usually measure for urinary catecholamines or urinary metanephrines or urinary vanillin mandelic acid. However, certain false positives can also be seen in some cases in patients who take certain drugs like tricyclic antidepressants, MAO inhibitors, ethanol, or sympathomimetics. It is usually advised that you should hold these medications for 2 weeks while testing for any urinary metanephrine or catecholamine levels. Also, major physical stress like hypoglycemia, stroke, raised ICP can also lead to false positives. So we can also look for plasma catecholamines and plasma metanephrine levels. Plasma catecholamines more than 2000 picogram per ml usually denotes a positive test. However, in these cases also, false positives can be seen as same as those patients who have false positives in 24-hour urine testing. And to look for plasma-free metanephrines and normethanephrines, which are more than 400 picogram per ml or 220 picogram per ml respectively. The above two conditions confirms the diagnosis. I would like to ask the expert what investigations are usually advised for this patient and how do you actually conclude the diagnosis of pheochromocytoma?
The one thing is catecholamines are secreted even in normal person episodically, and at depending upon his sensitivity, he can secrete large amounts of catecholamines. So what is important is we should have some parameter which will take into account these whole days variation and give us total days secretory pattern. So from that point of view, we would advise 24 hours urinary metanephrines, because metanephrines are metabolites of the catecholamines. But 24 hours collection is not possible in many patients. So people do on the spot fasting catecholamine in the urine can be done. But best is plasma-free metanephrines. They have been shown to be very fairly reliably high in all patients. If they are normal, they help us to exclude, you can say, pheochromocytoma. But if they are high, then you have to make I think you showed 2 or 3 times, we take 4 times. So if the cutoff value of the laboratory is say 150, then we would take more than 800 as positive. When in doubt, we will repeat it again, because this is going to decide whether you will do localization studies or not, whether you will change the medicines or not. About medications, most of the medications have to be stopped, but you can give calcium channel blockers freely. So they can be given, like amlodipine, deltiazine. These are both good drugs.
Okay.
And the dietary restrictions, which you probably remember from your undergraduate days, cheese, banana, chocolate, cocoa, something like that. All things which contain tyrosine. So that should be avoided.
Okay, sir.
And the sample should be taken in fasting state, lying down position, 15 to 20 minutes of rest, non-smoker person. Otherwise, they feel that they have to be resting, so they start smoking also sometimes.
Yes, sir. Okay, sir. Going ahead, the localization is usually done with CT abdomen or MRI. CT abdomen, usually the sensitivity is 95 to 100%. For extra-abdominal lesions, the sensitivity is around 90%. Now, MRI is considered more sensitive than CT to detect any extra-abdominal mass or any small lesions, and it is usually gives a less radiation exposure, to it is usually the preferred imaging of choice in pregnancy. There is another scan known as MIBG scan, whose sensitivity is around 75 to 90% and specificity is 95 to 100%, and it is usually detected by scintigraphy. So the management of any pheochromocytoma is resection. The preoperative workup is done with all the investigations as advised. 2D was usually done along with all the basic investigations to rule out any cardiomyopathy secondary to catecholamine release. So these are the various pre-op preparation regimens, which includes combined alpha plus beta blockade, which includes phenoxybenzamine, selective alpha-1 blocker, propranolol, other drugs like metirocin, calcium channel blockers like nicardipine. At this stage, I would like to ask, sir, what is the ideal medication to be started, and what are the other if not controlled, what are the other medications you usually recommend, and can they be continued on the morning of surgery, or should it be stopped prior?
When we decide that patient needs surgery, ultimately everybody will require surgery in these patients. So we admit the patient, and about 2 weeks before, he has to be volume repleted. So every day he has to receive 2 to 3 liters of oral, or if oral is not consumed, then at least 1 liter saline, along with oral 2 liters. Second is salt supplementation. We need to supplement 5 to 15 grams of sodium chloride every day, because these patients, because of alpha stimulation or vasoconstricted circulation, they are severely volume depleted. So first thing is volume correction, sodium correction. They are under observation when you start alpha blockade. Now alpha blockade has 2 types, non-selective and selective. Non-selective is better because it is phenoxybenzamine and phentoline. Phenoxybenzamine is long acting, to be started with the dose of 5 to 10 milligram and slowly increase depending upon patient's response. When you are monitoring the patient, orthostatic hypotension and reflex tachycardia have to be 4-hourly recorded by the nursing by the nurse. About 3 to 4 days of alpha blockade is taken as full alpha blockade if patient has controlled blood pressure. In a patient who already is normotensive, he has more chance of orthostatic hypotension. In such patients, you cannot monitor only BP and decide whether it's fully. So 3 days minimum is given for the time to get, and the dose you have to go on increasing till the BP is controlled. They may require 60 milligrams of phenoxybenzamine. Dibenzylene is available per month. And then after alpha blockade, we start beta blocker. Nearly 40 milligram TID of propranolol is also required. With these, most of them are controlled. But now the real problem is that when you allow the patient to the surgery, the phenoxybenzamine, being very long acting, is usually not given on the day of surgery, and some people will try to omit that even on the night of the before surgery, because post-operative hypotension is mainly with long-acting alpha blockers. Short-acting alpha blockers are selective, like prazosin, torrazocin, doxazocin. They are also used along with calcium channel blockers. They have less reflex tachycardia. And I think you will come to actual management of some crisis when you
Yes.
intubate or etc. So go ahead.
Yes, sir. So as discussed with Sir, the various drugs which are used as phenoxybenzamine, which is usually the drug of choice, but the side effects are usually orthostatic hypotension and reflex tachycardia. And there is perioperative hypotension shock, which is unlikely to respond to any pressor agent. There are also selective alpha-1 blockers like prazosin and terazosin. Even beta blockers can be used, but just after starting alpha blockade, but as rightly said by Sir, because it may precipitate hypertension in view of unopposed alpha agonism. If the BP is still not controlled by beta blocker, other drugs like calcium channel blockers and ACE inhibitors or metirosin can be used. Metirosin is usually a inhibitor of rate limiting step in the synthesis of catecholamines, which inhibits tyrosine hydroxylase, thereby causing a decrease in the synthesis of catecholamines. They are usually used in patients where the tumor is non-resectable or malignant tumors for long-term therapy. Other drugs like calcium channel blockers are also used. So we come to Roisen's criteria, which is used to denote whether our treatment is adequate or not prior to surgery. So it includes whether our alpha blockade is adequate. So the criteria includes no in-hospital BP reading more than 160 by 90 millimeters of mercury for 24 hours prior to surgery. Any orthostatic hypotension with standing PP should be more than 80 by 45 millimeters of mercury. The ECG should be free of STT changes for 1 week prior to surgery and no more than one ectopic beat every 5 minutes, which is observed. It also has other indicators for an adequate alpha blockade, like serial hematocrit levels are normal, are good RBS controlled, and there is improved psychological state. So now we come to the anesthetic management. Preoperatively, the patient was admitted 1 week prior to surgery for adequate hydration. The NBM status was checked and controlled. All medications were continued till the morning of surgery and proper informed consent was taken. Intraoperatively, the various monitoring tools used were NIBP, ECG, pulse oximetry, invasive arterial monitoring, and Ryle's tube. Epidural catheter was inserted at T12L1 level, and the case was induced with injection propofol 150 mg IV in graded dose, followed by injection vecuronium 4 mg IV as a muscle relaxant. In these cases, usually a short-acting muscle relaxant like succinylcholine and IV anesthetic agent like ketamine is usually avoided to prevent any sympathetic stimulation during induction. Other drugs like morphine and etracurium are usually avoided to prevent any histamine release during induction. The airway was secured with ET tube 7.5 millimeters cuffed Portex tube. Then anesthesia was maintained with oxygen, nitrous, and sevoflurane, and a total of injection vecuronium 7 mg was given. Intraoperatively, an epidural top-up was given of injection bupivacaine for analgesia. Intraoperatively, when the surgeons handled the BP went up to 200 by 120 millimeters of mercury and tachycardia was noted. The BP was controlled by the following of nitroprusside infusion. Now, nitroprusside is usually the drug of choice for the patient to handle any hypertensive crisis, as it is a very potent drug and a direct vasodilator and has an immediate onset of action. It is usually given at a dose of 0.5 to 10 mics per kg per minute. As the patient has noted tachycardia, esmolol was also given at 10 mg per 10 plus 10 mg IV bolus, followed by infusion. Though in this case, these two drugs were used. The other drugs that can be used along with this are IV phentolamine, which is a competitive alpha blocker and a direct vasodilator, injection labetalol, nitroglycerin, and injection MgSO4, which inhibits the release of catecholamines from the adrenal medulla. In this case, no intraoperative arrhythmias were noted during the whole surgery. But the drugs which can be commonly used are lignocaine, which is short-acting and has minimal negative inotropic actions, esmolol, and amiodarone. Amiodarone is usually used in supraventricular arrhythmias. Finally, once the mass was isolated, BP fell to 80 by 40 millimeters of mercury, following which the nitroprusside and esmolol infusion was stopped. Rapid IV fluid was transfused to maintain the BP. An injection phenylephrine was given at a bolus of 100 plus 100 microgram was given. Though this phenomenon is commonly seen when the tumor is ligated, it can usually be prevented with good volume expansion with IV fluids prior to ligation of the tumor. And in some cases, if the anesthesia depth is too deep, it can a decrease in anesthesia depth can also help in increasing the BP to a certain extent. In cases where there is bilateral adrenalectomy performed, glucocorticoid therapy should be given. Once the surgery was done, the patient was reversed in injection by glycopyrrolate 0.5 milligram IV, followed by injection neostigmine 2.5 milligram IV. Proper extubation was done after reversal, and patient was vitally stable following extubation and maintaining saturation. Supplemental O2 was given, and patient was shifted to the recovery. In the post-operative period, strict BP monitoring was done to look for hypo or hypertension. Glucose monitoring was done strictly for 24 hours, as lack of catecholamine effect on the beta cells leads to increase in insulin levels, thereby leading to hypoglycemia. So glucose monitoring for 24 hours is very essential. Epidural top-ups were given regularly for adequate analgesia, and the catheter was removed on post-op day 2. The patient was observed in the ICU and shifted to the ward on post-op day 2, thereafter discharged in 7 days. So it is usually said that around 3 to 5% of people have chronic hypertension following pheochromocytoma. I just wanted sir's opinion if this is really seen in actual scenario.
Yes, that is true. Because people who have tolerated hypertension for a long time have developed arteriovascular changes. And those changes keep on, maintaining the hypertension. Secondly, these patients also have hypertensive nephropathy that also keeps on continuing as renal hypertension is sort of. About most of the patients need 2 to 3 days to, fully become normotensive. And if there is some, you can say, residual tumor remaining, again, that is one of the important cause of sustained hypertension. But that should be investigated only 6 weeks after the surgery is over. Bilateral pheochromocytomas can be discovered like this. Familial are usually bilateral. And as you said correctly, if surgeon is planning bilateral surgery, then you should start hydrocortisone right on the day 1 or day 0 of on the day of surgery only in replacement and stress doses.
Okay.
Otherwise, okay, most of the things you have covered very well.
Okay. Okay, so to conclude, various anesthesia challenges which are usually seen in pheochromocytoma are adequate preoperative preparation needs to be done with alpha blockers, followed by beta blockers if required, with restoration of intravascular volume, which is minimum 10 to 14 days prior to surgery. Intraoperatively, avoid provocation of catecholamine release by anesthetic drugs like scoline and maneuvers like laryngoscopy in light planes of anesthesia to suppress any adrenergic response to surgical stimulation, to minimize the hemodynamic response to tumor handling and devascularization, and most importantly, a good communication between the surgeons, physician, and anesthesiologist is very important. Thank you.
I think I will add metoclopramide as an important drug which can precipitate hypertensive crisis in these patients. So if you are going to give something to prevent nausea, vomiting.
Yes, sir.
Any questions?
So very nice presentations, and the case presentation, the last case presentation of pheochromocytoma was very, very good. So there are a few questions on the chat box, so I'll take them. A minute. So one question is, asymptomatic patient, what is the TSH cutoff for elective surgery under general anesthesia? I think you've already answered it, but still you can just make it.
Ideally, patients' TSH should be less than 5, but up to 10, as we said, subclinical hypothyroidism can be taken for surgery, elective surgery also.
Okay, sir. So there's one more question: how to manage a patient of brittle diabetes intraoperatively? How frequently we should check blood sugars? That also you answered. But
diabetics are usually type 1 diabetics, and they are already on insulin. So you start these patients, as we discussed, on insulin infusion drip. And since half-life of insulin is 30 minutes, you have to check the blood sugar every hourly on glucometer, point of care sort of thing. And keep on giving or omitting the correction doses depending upon the blood sugar every half an hour or 1 hour.
Okay. So there was one discussion about ERA's protocol and carbohydrate loading. So for diabetic patients, I just wanted to add that we are routinely following the carbohydrate loading in most of the patients. Also in diabetic patients, we are not giving carbohydrate loading, but we are giving clear fluids like black coffee or black tea, tea without milk. And at least if not anything, you at least give them water so that takes care of hydration. So, and it's safe. Like there was some concern regarding the regurgitation and all, but even in diabetics, where we are expecting some amount of gastroparesis, so there also 2 hours fasting, we are giving clear fluids and there's no problem. So that's the point I wanted to make.
Good, I will read about it.
And also regarding one hypothyroid patient. So I would like to just share one experience that once in my private practice, that was a very long time back. So I was doing a case, simple procedure. I think it was cervical lymph node excision or something, a very small procedure. So where, minimal investigations were done for that case because it was a small procedure. So just basic CBC, X-ray and things like that were done. And thyroid function tests were not done. Patient was not a known hypothyroid. And then the surgery got over and the patient was just not coming out of anesthesia. So I was wondering what happened, and then I tried everything, but then it was she was taking too long to come out. Then the relatives had some file and I went through that, and then it was the file, the investigations revealed that 6 months back her TSH was more than 100 or 120. It was a very high value. And obviously that was done 6 months back. So even the surgeon had not seen that file, and luckily the patient had it on that day. But it was a very difficult to get the patient out of anesthesia and extubate, and it required a lot of patience, but I could extubate her after 2 hours. So the point is, whenever you've ruled out all the other causes why the patient is not coming out of anesthesia and you're not able to extubate, maybe hypothyroidism, which has gone undetected, that is the reason.
Whenever you get very, you can say, difficult to interpret thyroid results, the commonest cause is actually non-compliant patient. Sometimes he takes the tablet, sometimes he doesn't take the tablet, and the thyroid function report is totally haywire because of non-compliance.
Yes, sir. So it was a great meeting. I hope there are no more questions there. I can't see any questions in the chat box. So in the end, I would like to conclude by giving the vote of thanks. So it was a great meeting, and we really enjoyed. I, the Secretary of Thane ISA, Dr. Parna Thakkar, take this opportunity to thank all of you. I thank Society of Anaesthesiologists, Maharashtra State, SAMS, for providing the Zoom platform and supporting this meeting. I thank SAM's President, Dr. Balaji Asegaonkar, Honorary Secretary, Dr. Rajesh Tagadpalle, sir, for their best wishes and conveying it to us. They tried to actually log in, join, but they were busy in the OT, so they called and said that they were busy. But thank you for the wishes. I'm thankful to our seniors, other senior members of the SAMS for joining in. I thank Rajiv Gandhi Medical College and its team, Dr. Vijay Patel, Dr. Ketki, for her great enthusiasm and for arranging this whole meeting and her ideas. Dr. Anmol, Dr. Radhika Ganesh for their enthusiasm and for making this webinar possible. I'm grateful to Dr. M.H. Patwardhan, sir, for guiding us and for chairing the session. It was indeed a pleasure to have you on this platform with us, sir. Thank you very much.
Thank you.
Thank you, sir.
I think the session has gone so well.
Yes.
In the next few months, we can plan an endocrinology and anesthesia part 2. number
Yes,
two.
yes. And actually, we have a lot of questions. Like if we meet in person, maybe if we have a physical meeting, I'm sure there'll be many more questions.
Yeah, definitely.
There's so many things regarding endocrine where, our knowledge is, as anesthesiologists, our knowledge is little less about all these uncommon conditions. And then whenever we get stuck, we think, endocrinology reference, and that's how we get over it.
Ma'am, we will arrange a physical meeting the next time we visit Thane.
Sure, sure. Thank you.
We
Thank
will
you
really
for
look forward to having Dr. Patwardhan in Thane for some meet in the near future.
Yes.
Thank you for your warm feelings. Thank you, Madam Ghosh, Madam, and thank you. Thank you all members.
Thank you, sir. Thank you very much. Thank you.
Present.
Actually, congratulations, Dr. Parna, Dr. Dr. Manisha and team, Dr. Ketki. It was excellent presentation. Thank you.
Thank you so
Thank
much.
you.
Thank you. I'm
Okay.
grateful to our founder member and GC member, Dr. Sunil Katkade sir, for always guiding us and joining the meeting. And always he is there for our hand holding. Whatever problems we have, we run to him and he's there to solve all our problems. So thank you, Dr. Manisha Ghosh, our Thane ISA president, and Dr. Nilima Kelkar, our treasurer, Thane ISA, for all the help and the guidance. Thank you, our past president, Dr. Meenal Gadgil, for joining, and all the other committee members and Thane ISA members for joining in. Many thanks, Thane ISA members and all the delegates for joining in large numbers. And we were so happy. We were so thrilled with that overwhelming response. And there were more than 250 registrations. So it was very, very heartwarming. So thank you for all that. I appreciate Mr. Ganesh from Genica for the Zoom platform support. And I really admire his patience. He was so patient while making the flyer, and those small, small mistakes he was correcting and sending it out, and solving all our IT difficulties. So thank you all. I cannot conclude without thanking Mrs. Leena Jangam Pragati and her team for all the MMC coordination and felicitating with the registration process, especially the Google form. So again, here there were a lot of queries and they solved all of them. And I thank our MMC observer. Thank you very much. It was a great meeting. It was a pleasure. And if there are any more questions, you can ask on the groups later. So
Thank you.
Okay.
So, sir, just excuse me, since the meeting is over, can I talk for 2 minutes?
Yes, sir. Yes, sir.
Yeah. Sir,
Ganesh, you can stop
endocrinology.
recording now.
Yeah, you
Please
can stop recording. So, endocrinology is such a complicated and advancing subject. Of late, I've been doing some neuroanesthesia, and the more I do, more I realize how little I know. Today, so today I did a pituitary and so many cortisone levels and prolactin and lots of things, and sodium levels are to be monitored right now. So it's a very interesting subject, and I think it's a team approach. What is most important when you are dealing with any endocrine case, particularly. This is what small comment, and that's a great effort. And thank you very much, sir. Thank you very much for joining.
Thank you for inviting.
Thank you. Thank you. And I think, as Dr. Manisha said, we must have one more webinar on endocrine part 2.
Definitely. Because sir,
And-
I have seen in recent times now, especially gynecologists, they are very
Yeah.
good, but they tend to label everything as PCOD. Whereas it is
Yeah.
not PCOD many times, and there is something hidden, and then it comes up as an adrenal tumor, which also they call just incidentaloma. But that is also not the case, and these girls need to be like properly investigated. So definitely a part 2 is in the line sometime.
For, as I said, for pituitary, parathyroid, and some difficult adrenal cases again.
Yes, we must.
Definitely.
Yes.
I
And
think
long-
that time we can have sir in Thane.
Insulinoma is a good case.
Yeah. I think that time we can have online, offline meeting.
Offline, yes.
Yes, sure. Plus, thank you, sir. Thank you very much. Thank you.
very
Congratulations,
much.
Manisha, Dr. Parna, Dr. Ketki. Thank you very much.
Thank
Sir,
you,
now
everybody.
since you
Yeah.
mentioned about pituitary, I'm just remembering last Sunday at ISNAC at Pune, the National Neuro Conference, I gave a talk on
Yes.
diabetes
Yeah.
insipidus, and so how much of literature I have read. So
Yeah.
cerebral salt wasting, diabetes insipidus, all these are very, very complex subjects.
Yes.
So, yes.
We must have good endocrinology. You know, I think as an anesthetists or intensivists, we must have a good team.
Yes.
Yes. And I just want to share one incident. Almost, I think, in somewhere 1991, when pulse oximeter came first in the country, and I had one of the third pulse oximeter. So I was called to conduct a case of bilateral pheochromocytoma at Malad. And it was a bilateral pheochromocytoma. And that entire OT has about 8 to 10 people attending, 2 anesthetists, surgeons, nephrologists. And end of the surgery, Manisha, are you hearing with me?
Yes, sir, of course.
It was very,
Yes,
very
yes,
difficult.
yes, yes.
It was a cardiologist nursing home, hospital, and that was the operation theatre. And at the end of the theatre surgery, we realized that we could not ventilate the patient. The patient was not getting ventilated. Her oxygen saturation was getting, not maintaining well. And then somebody said it's a bilateral pneumothorax. Somebody said we got X-ray chest. And then what we realized that we were shifting the position. The tube was just on the cords.
Oh.
We deflated the tube, and so these are, and that particular bilateral pheochromocytoma, where lots of discussion whether to do both the sides simultaneously or to do one side and do other side. So what was decided that we'll do first side once. If everything is stable, then we'll go for the second side. And the patient had financial constraints too. So these are very interesting cases. Thanks to Manisha. I think Dr. Patodhan, sir, thank you very much for joining us. Thank you. Appreciate it, sir.
Thank you, Ketkari.
Yes, sir. Okay, sir. Thank you.
And
Thank you.
Dr. Patwardhan. Thank you.
Thank you. I
And
think
good night.
this CME we must put on our YouTube. Huh?
Yes, sir, it will go on YouTube. It is already on YouTube.
Yes.
So we had
Yeah.
100 people who had logged in here, and there were another 30 or 40 on YouTube.
Yes.
So
It was very, very well attended.
So you must put this series on
Yeah,
YouTube.
it is
It was
already on
very
YouTube,
good.
sir. I have shared the link also.
Very, very interesting. Okay, thank you. Thank you very
Kirti
much.
and
Thank you.
Vijay, we will definitely have one more project for you.
And
Thank you,
yeah,
Parna.
Yes.
I think Manisha, what we can do, we can have some cases. Hi Vijay, where were you? Chalo, okay, boss. Thank you.
Okay. Long live I say, long live Thane, Thane I say, Jai Maharashtra.
Jai
Good
Maharashtra.
night.
Right.
And Vijay, where are
Ah,
you?
sir.
How many people from Thane are RGMC are ISA members?
Sir, those who, apart from the resident, most are.
नहीं सबको करने का ना fees are going higher and higher.
Yes, sir.
Yeah, 1st April it will become 10,000. So before that, everybody become members. Now
Actually, our SRs are ISA Mumbai members. They are members of ISA Mumbai.
Who?
Most of them.
But are they
SRs,
volunteering
SRs.
in Thane?
Ask them to change to Thane.
No, they won't be staying. They come for 1 year. So
Yeah, no,
Okay,
that becomes very difficult with
but at least,
students.
But kindly encourage the youngsters to join, because
right,
they
right.
get
Those who
advantage.
are staying in Thane and around Thane, we will encourage them to
Yeah,
join.
correct.
See, there are lots of advantages. First of all, you get a hard copy of a journal. Getting a hard copy, a printed copy of a journal is it's an expensive thing. Plus, you can join CMEs, webinars, and get advantage of our insurance. ISA insurance scheme, that is. So, Vijay.
Yes, sir.
So bug जरा काहीतरी करा.
Oh, lucky sir.
You're a
Madam,
member, no?
thank you very much.
ISA member है कि नहीं तू? ISA member है कि नहीं तू?
Hi,
Yes,
sir.
sir, yes.
आम्ही आता rule केला आहे की only ISA members can present papers in our webinars. Nobody else.
Yes. We must. Okay, chalo.
Yes, thank you,
Okay,
sir.
then bye.
Good
Thank
night.
you.
Thank you.
Bye. Bye.
Good night. Good night.
I'll end the meeting.
Yes, ma'am.
Yes.